good morning, good afternoon, and good evening to all of you who are joining us from different time zones. And a very warm welcome from India. A special thanks to the AERO Scientific Committee for this opportunity to present my thoughts on Cyberknife Radiosurgery for AVMs. Now, this webinar, I'd like to take you through 4 parts. One is just the broad overview of the radiosurgery. Second is an overview of the imaging, basically with the different modalities available. And then we will go on to the contouring part. And finally, we will see some case examples. So let's get started with the first part. And let me start by saying that decision-making in AVMs is not very simple. And it depends actually on a number of factors which are mostly to do with the clinical situation and the natural history of the particular AVM that we are wanting to treat. Now, radiosurgery is something which is best used for deep unruptured and even superficial unruptured AVMs. And this used to be the scenario because for deep unruptured AVMs, there was really no good solution available. But in these days, patients want lesser invasive options of treatment. And therefore, radiosurgery has a role to play even in superficial unruptured AVMs, for which actually I would like to offer surgery myself. Surprising is that even for some ruptured superficial AVMs, the patients would rather have a radiosurgery treatment, but then that needs careful counseling and letting them know about the latency period. So the decision making is pretty complex. It depends largely on the natural history and the morphology of the AVM that we are wanting to treat. Now, along with that, the important issue is that the Aruba trial has laid a certain emphasis on observation as a treatment for many of the AVMs. Now, without going too much into the decision-making part, let me say that there are some advantages of radiosurgery that are well proven. One is the non-invasive nature of the radiosurgical treatment. The second is the proven long-term reliability across hundreds of scientific reports of high quality, and the long-term durability of the radiosurgical effect. Now, one very attractive attribute of the radiosurgery for AVMs is that it is relatively independent from the angio architecture. So that is something which is very valuable to be used for a particular patient. Now, for those of us who are new to radiosurgery, there is the definition of radiosurgery for you. And this is just what the Cyberknife is, what the Cyberknife system consists of. It's basically a very compact linear accelerator mounted on an industrial robot. And this compact linear accelerator basically then shoots individual beams onto the target in the patient from different angles and achieves a very high degree of conformal radiation delivery with a very steep fall off outside of the area of interest. Now, how does radiosurgery act in the first place? So there is a large body of literature and some very elegant studies, including some histochemical studies have been done to show us that it's basically the occlusion of the small vessels that comprise the AVM. And that's the late phase reaction, which typically begins 6 months post radiosurgery and is usually complete by 3 years. And at the molecular level, certain molecular entities like vascular endothelial growth factor, E-selectin, VCAM1, among the cells such as endothelial cells and myofibroblasts are all implicated in this very interesting late phase reaction, which we use to the benefit of the patient whenever we do AVM radiosurgery. Now let's start with the AVM imaging. Now the traditional AVM imaging, which all of us consider the gold standard, is the DSA. And again, the traditional approach to radiosurgery with the gamma knife, for example, basically uses a co-registration of the planar images that you acquire from the DSA and they are overlaid on the axial MRI sections. But that is doable in the case of the Gamma Knife because you are doing it as a frame-based treatment, and therefore the spatial geometry of the imaging space is defined both in the MRI and in the DSA suite by using indicator boxes. Now, it's not without its limitations. For example, in this study in AGRIM BP, it was shown very well that if you use this simple planar imaging model with the Gamma Knife, you can overestimate the size of the AVM, an example in this image in the lateral view. And in Cyberknife, basically because we are doing everything frameless, it was basically Professor Colombo, and I was very privileged to spend a week with him in Italy, is to do this using a 3D rotational angiography. So in this report, which was published in 2009, Professor Colombo laid out very elegantly the technical parameters and the method of doing a very high quality radiosurgery using a 3D rotational angiography. So at our center, what we do is something very similar. You see this 3D rotational angiography being done and the 3D image data set being acquired. And in our center, what we use is the Philips system, and what this is called is the Vaso CT. In a Siemens system, it would be called a Dyna CT, but essentially it is a very fine quality cone beam CT. And in case of an AVM, for example, it gives us a wealth of information, not only about the AVM nidus, but about the presence of other vascular structures in the proximity of the AVM. Now, the advantages of this Vaso CT, which is basically a very fine quality cone beam CT, is that it is a very high resolution imaging. And I would like to draw your attention to this image here, in which you see the brainstem, the basilar artery, and the PCA, and these fine perforators as they enter the substance of the brainstem. Now, this kind of a high resolution of 0.1 millimeters is not achievable by using a standard CT angiography or a MR angiography, which is used in many institutions for Cyberknife radiosurgery. Only 25% of the normal quantum of contrast is used for this, and it adds only 5 minutes to do this when you're doing a DSA for the patient. Now, in terms of the spatial resolution, you will be surprised to know that conventional DSA and most kinds of MRA and CTA have this spatial resolution which is 1 mm or worse, and these fine kinds of cone beam CT-based CT angiography have literally a resolution which is in the region of 0.1 millimeters, and this is a reflection of the voxel volume whenever we use these imaging entities. Now, there is a lot of literature support to tell us that this is actually very valuable for the patient. And in this particular publication by Dr. Conti from Italy, he showed that there was clearly a 10% reduction in the marking of the AVMs by using this fine high quality cone beam CT angiography. And there is also a report by Holmes et al. In 2018, in which actually they described 4 patients in whom the AVM could only be visualized by this fine cone beam CT angiography, and these 4 AVMs were inadequately visualized by either MRI, MR angiography, CT, or CT angiography. Now, given this useful technique which we have, so this is what an AVM looks like on this fine quality cone beam CT angiography with a 0.1 mm spatial resolution. So you see the AVM, and if you saw the very bright embolization material also inside the AVM, this imaging data set can basically be exported to the Cyberknife suite. And you see this table on the right side with all this technical information, which of course is easily available. And this then forms a very important data set to start contouring the AVM. Now, before we start using this imaging data set for contouring, one very important step not to miss is to check the fusion personally with the planning CT scan, which as we know is the primary imaging data set for the Cyberknife. Now let's come to the contouring part. Now contouring is one thing which is very subjective, and there are a number of studies which show that between different people who are contouring, there can be a huge amount of variability. For example, in this study published in AGRIM in 2006, if you look at the highlighted part of the table, you would be surprised to know about the kind of variability which can exist between, in this particular patient, in this particular study, between two different observers who were contouring the meningiomas. And this is a study published in AGRIM in 2005, in which the conclusion was that there is a very substantial inter-observer variation when contouring brain AVMs. So this is a significant problem from institution to institution. And what basically I would like to also highlight is that although we consider DSA as the gold standard of AVM imaging, we have to understand that the final delineation of the target volume has to be done on a high quality 3D imaging data set such as the MRI. And in and around the AVM, there are many vascular structures that are visible. For example, the true nidus is of course what we need to give the radiosurgical treatment to, but very importantly surrounding it are the draining veins. There may be some venous angiopathy surrounding the AVM. There can be venous pouches which are visible, and you can see those in this particular image on the right side. And of course, there can be AVMs and new vascularization. So what I like to do is when I'm contouring is to look at the vaso-CT and the MRI images. So scroll along the entire length of the AVM to get my bearings. What I then like to do is to choose a contouring tool and start contouring the AVM from one end. So pretty soon you will start seeing a purple contour, which I will be drawing on the vaso-CT. And you will see it projected on the T2 MRI on your right side. And I will keep on modifying as we go along the different sections in which the AVM is visible. The attempt is to exclude the draining veins, only include the proximal part of the draining vein as it exits the AVM. Subsequently, I like to use the MRI to more precisely define my contour. And in this, you will see that I'm using the 1+1 window with MRI images on both the sides. One is a T1 contrast and the other is a T2. And basically, I'm excluding this large venous channel. And as we go along the sections, I am excluding normal brain tissue, which does not seem to be a part of the AVM. So using this process, one can arrive at a reasonable AVM contour. Now, this is in a nutshell what I was talking to you about, is that I begin with vaso-CT as the starting point, and my contour can be slightly generous to start with. And I finish by using the MRI images, both to exclude the brain tissue and to include the small parts of the AVM, especially at the edges, which could be missed on the vaso-CT. Now, whenever treating complex AVMs, one thing which I have found very helpful is to use all the help from my neurointervention colleagues. And this is my neurointervention colleague, Dr. Vipul. And together we are discussing when I'm contouring one of the complex AVM cases. Now, a little bit about the AVM dose. It's pretty clear that we do not need to use more than 25 grays at the margin because it would just lead to higher toxicity. And at the same time, anything less than 15 grays would be quite ineffective. Now, there is a lot of data available in a particular patient how to zero down on a particular dose. So there is this RTOG dose data, which is familiar to all of us. And of course, by using other dose calculation, the 10% risk of radionecrosis can be calculated using certain other equations. But really, I've become a bit conservative in my radiation dose. And I like to use the full dose only in AVMs, which are about up to 2 to 3 cc's in volume. And this is what I've tried to show in this table on the right side. And as the AVM volume increases, I like to dial down the dose accordingly. Now, any AVM which is more than 10 cc's, by and large, I would like to not treat in a single session. Although at times I have treated AVMs which are about 12 to 13 cc's, but anything larger basically would need either volume fractionation or a dose fractionation. So dose is something which is very critical to the success of a radiosurgical treatment, but then one has to be mindful about the risk of complications. So for example, in this study of brainstem AVMs, there was a clear difference in the probability of obliteration between those that received more than or equal to 20 grays and those AVMs that received less than 20 grays. Now, let's move on to some illustrative cases. Now, this was a patient with a left thalamic AVM, and you can see the AP and the lateral angiograms. This patient had a history of prior bleed, but there was really no good endovascular option available. And this is the vaso-CT, which shows you very nicely the actual AVM and the arterial supply and the venous drainage. So this was the outline of the AVM that we finally landed up with using the MRI and the vaso-CT. And we developed a highly conformal plan because in this location in the thalamus, there are high chances of leading up to adverse radiation effect. So this is the contour of the AVM. And this was the analysis if we were just using the MRI information, that is the contour in green, and integration of vaso-CT is the contour in red. So we found that between two independent people who were contouring this AVM, we could reduce the contoured volume from 2.4 cc's to 1.5 cc's, which is a significant reduction and will significantly reduce the chances of a radiation adverse effect for this particular patient. So this was the final plan. If you take a look at the conformity index, it's quite good at 1.22. And the 12 gray volume was a shade over 1 cc's. And we were treating this with 18 grays to a single fraction. Now, another case of an unruptured left-sided posterior temporal AVM. And the interesting thing to see from this particular contour is that there are a number of venous channels which are around the AVM. Using an angio-CT and combination with the MRI helps us to zone on a contour which is very, very selective, and we would like to contour the AVM alone, which is basically the area of the shunt, and excluding these venous channels around the AVM significantly reduces the chances of complications. This is another patient with a tectal AVM, which is a bit more on the right side. And if you see the vaso-CT images, which are on the left panels, you can realize that why vaso-CT is such a valuable modality. Otherwise, you would be hard-pressed to contour the AVM using just the MRIs, the T1 and the contrast T2 MRIs, or use CT angiography or MR angiography, which would not have the fine resolution of the vaso-CT. Another example of a motor cortex AVM, and this particular patient had a lot of venous angiopathy surrounding the arteriovenous malformation. And in the motor cortex, you can again appreciate why it is so important to have a very selective contouring of just the AVM. In many of the centers, there may be a possible policy of contouring almost all the vascular structures that you see, but clearly that would expose this patient to a high risk of complications. So in this particular case, we were able to treat this AVM with a 15 gray single session treatment. And this is another section of the contour showing that the main draining vein has to be excluded to avoid a high risk of complications. This is another case in which there were two separate AVMs, and with the area of bleed in the past, which was in between the two parts of the AVM. And using the angio-CT or the vaso-CT, it was very, very useful in landing up with a good contour. And I distinctly remember that even using the DSA images, we were not very happy with the contours we were landing up with. So this is the final contour of the AVM, which we treated at 18 grays to a single dose to both the AVMs. And basically we landed up with a very, very steep fall off plan, excluding normal tissue. And now a word about the obliteration rates. So typically the expected obliteration rate after an AVM radiosurgery could vary anywhere between 70 to 90% at the end of 3 years post radiosurgery. And the factors which have been known to influence are typically the size of the AVM, which will of course determine the dose, and the location of course also determines the dose. And apart from that, extremely high flow AVMs have lower obliteration rates. So the obliteration rates can actually be predicted very nicely. And one example is what we call as the obliteration prediction index, which is nothing but the margin dose of the AVM in gray divided by the AVM diameter in centimeters. So once you have the value of the obliteration prediction index with you, based on this curve, you can pretty much calculate the probability of obliteration. And this is something which is very valuable for a pre-procedure counseling of the patient and the family. Another option is to use the so-called Pollock-Flickinger score, in which you multiply 0.1 by the volume of the AVM, then 0.02 by the age of the patient, and 0.3 by the location of the AVM. This particular grading score, although not being as easy as the last one, has also been shown to have a very high degree of correlation with the actual observed obliteration rate of these AVMs. Now let's talk for a few minutes on the radiosurgery for pre-embolized AVMs. So this is always a bit of a sticky problem, and the problem really starts from when you want to mark or delineate the AVM. Now, one of the problematic scenarios is when you have multiple scattered sectors of an embolized AVM, and as you can see in this slide, it is really a nightmare to develop a good contour which is safe for the patient. Apart from that, presence of onyx, which is the favored embolization material, leads to problems, potential problems in absorption, shielding, scatter of the radiation, and so on. And of course, if the embolization has not been good, and basically what has happened is just the feeder embolization, then really there can be high chances of recanalization of AVM in the future. Now, the post-embolization AVMs have clearly a lesser obliteration rates than a de novo or a virgin AVM. And this has been shown repeatedly in data from different institutions. This is the UPMC data from 2009. And basically, one way of looking at this data is that the embolization should be done only when it is necessary. such as the indications in which if it is a large AVM, or if there is a perineidal aneurysm, or if there are fistulae, or if it's a very high flow AVM. The AVM embolization should not be done thinking of it as a trivial decision, or just thinking of it as the first step in the management of an AVM, even if it is a small AVM. Now, one way of looking at this data is that typically we do primary radiosurgery for the easier, compact, small AVMs, and we like to add embolization for the AVMs that are more complex. So in these more complex AVMs, a slightly lesser obliteration rate may not be a bad trade-off. So let's look at some case examples of post-embolization cyberknife radiosurgery. So this was a lady with a left frontal AVM embolized twice. In this DSA image, I'm sure you can appreciate a lot of embolization material. And you can see the same in this lateral view. You can see a lot of embolization material. And this was the vaso-CT of the same patient. And if you look carefully, you will be able to see the embolization material as a very hyperdense signal, and the rest of the AVM can be clearly seen apart from the embolization material. So for this patient, what we needed to do is a very careful delineation of the AVM. And as I already mentioned, the major venous channels have to be excluded from the contour. So you can see this large venous pouch, which has been excluded from the AVM contour, and this embolization material lying laterally in one of the veins has also been excluded from the AVM contour. Now, doing this kind of a contouring, this was an AVM which was 8+ cc's in volume, and we decided to treat this using a dose of 16 gray single fraction. And you can see that this was a very nice plan which was developed with a conformity index of 1.13, and the V12 was just about 4 cc's, which is a good figure, which will prevent any major complication rate for this patient. Now, another case in which what I would like to show is that for these small compact AVMs, embolizations should not be done as thinking of it as the first step in the treatment of the patient. So this patient, a 25-year-old, came to us with this unruptured AVM, but somebody had already embolized it partly. And what we really needed to do in this case is to include the entire AVM, including the embolized part, in our contour. And we were able to give a high dose of 20 gray to this AVM, including the embolized part. And this patient did very well. This is the post-Cyberknife 2 years angiography. If you look carefully, you will see some embolization material here, and there is no AVM to be seen. Now, pre-radiosurgery embolization is very much required for complex large AVMs like this. So this is one patient whom my neuroendovascular colleague embolized 4 times. And at the end of this, I gave Cyberknife radiosurgery. And this is 2 years after Cyberknife radiosurgery. The AVM is completely cured. In some situations, even for ruptured AVMs, we are called upon to give radiosurgery because there is no good surgical or endovascular treatment available. And even in those situations, one can get by without any complications. So this is one case in which this is pre and 3 years post radiosurgery using 20 gray dose to this deep frontal AVM. Another example of a pre and post 3 years radiosurgery for this dominant perisylvian AVM. And the thing which I would like to mention here is that there, to my mind, there are 2 main factors for success in AVM radiosurgery. One is the selectivity both of your contour and your planning, and both these together make sure that only the AVM gets the radiation. And what helps is to have a plan which has a high degree of conformity and with a steep radiation fall off outside the target volume. Now, as I said earlier on in my presentation, in treating AVMs, collaboration is something which is very, very important. Typically, we talk about first embolizing and then doing radiosurgery. So this was one of my earlier cases in which we did radiosurgery. And what we saw after 3 years, that there was still a small fistula remaining, and this then needed embolization. So what I would like to say in this slide is that surgery, embolization, and radiosurgery are complementary modalities, and it is possible that a certain AVM may require these to be done in almost any order. Now, what is the ideal AVM case for radiosurgery? So typically, this would be an unruptured AVM. This would be a compact nidus, by which I mean it has more or less, as far as possible, a spherical shape. It is not very eccentric, and it is not very diffuse. It does not have irregularities in the contour. The ideal size would be around 2 centimeters in diameter, volume less than 5 cc's, location lobar rather than in the brainstem or the thalamus, low or moderate flow, no fistula or aneurysm or a significant venous hypertension, which is visible on the DSA images. But the value add of the radiosurgery is that, barring these few factors, the radiosurgery result really does not depend on the angio architecture of the AVM in terms of the number of feeders or the presence of end passage feeders. These are factors which preclude good endovascular treatment of some of the AVMs. So this is my description of what I would count as an ideal AVM case for radiosurgery. Now, this slide is to say that not all AVMs merit treatment. So this is one example of what you call a diffuse AVM, in which there is normal brain parenchyma between the AVMs, as you can see here on the MRI. And these kind of AVMs may not really merit any particular treatment. So complications can be seen in a small proportion of the patients. I think it is more to do with the dose and the volume and the location. And this can be seen from this publication from the Pittsburgh group in Clinical Neurosurgery 2008, that as you go towards AVMs that are larger in diameter and AVMs that are in the moderate high risk and the high risk regions, specifically the brainstem and the basal ganglia, the complication rate increases geometrically. Now, our experience so far has been, we've used this treatment modality now for 2.5 years, and we've treated 48 cases in these 2.5 years, of which 8 cases have been deep AVMs. But in the past 2 years, we have not landed up with a single case of adverse radiation effect. We have had 2 bleeds in the waiting period, but both were among these 8 cases with deep AVMs. And we have some check angiograms that are now starting to happen. One of the cases, of course, which I presented. So to summarize my talk, what I would like to say is that radiosurgery is increasingly important method for treating AVMs. And I think in most centers, it constitutes anywhere between 10 to 20% of the intracranial work. A use of a high definition 3D rotational angiography enables high quality of contouring. And contouring, I believe, is one of the key ingredients for a good radiosurgical procedure. The 3D rotational angiography, as I've presented, has advantages over using CT angiography and MR angiography. And attention to key elements of contouring and planning in a particular case is extremely important to achieve good outcomes and to minimize the risk. At the end of it, what I would like to say is it's all about good teamwork between radiation oncology, neurosurgery, physics team, technology team, and the neurointervention team. So with this, I'd like to thank you for your time in listening to this presentation. And I would like to acknowledge the help that I received from my neuroendovascular colleagues, Dr. Vipul, Dr. Raj, my neurosurgical colleagues, Dr. Sanjeev, Dr. Pavan, my physics team, especially Jeffrey and Prasob, and of course, the excellent support from Accurate team, Lindsay, Lisa, Vertika, and Piyush. Thank you so much.